As you'll see from this, this is the Neil Kelly and Jimmy Marshall show, but there's a problem in that Jimmy is obviously not here today. We normally advertise this as a little intimate at home with hinge and bracket, and Jimmy hasn't owned up to whether he's hinge or bracket yet. Anyway, I suppose the reason for saying that is that it's meant to be relatively, these sessions are meant to be relatively informal, and obviously there'll be lots of opportunity for discussion and questions. Anyway, we're here to think about integration, that process of bringing together two functions, if you like, and that's certainly what bringing health and social care together is all about. How many of you did higher maths, A-level maths? Oh, well, this will be an easy. Remember this? No? Yeah, this is the formula for integration. It's really very straightforward to learn, as you can, I'm sure, can.
Oh yes. Of course.
I think the message really is that actually the process of integration is far from simple. This is going to be really quite difficult. There are all sorts of complications for us ahead, and the sooner we get started, the better, I think, probably. So the other thing I was going to do just at the start really was to try and use a little video clip from the King's Fund to illustrate why we might actually want to do this, because you might well say, well, is this not just another blinking health service reorganisation? And often these things feel like that. So I think this is quite a useful way of just demonstrating, if you like, why we might want to do this.
Over the next 20 years, the number of over 85s in the UK will more than double, meaning many more of us with multiple long-term health conditions. Our current health and social care system won't cope. Fundamentally, it's the same system as when the NHS was set up, designed to treat episodes of illness one at a time. Already, we're failing to give vulnerable people the care they need, and we're set to run out of money fast. Meet Sam. He's 87 and suffers from emphysema, a disease that makes it hard to breathe, and also has type 2 diabetes and arthritis. Sam was coping pretty well until his wife passed away, but is now lonely and increasingly depressed. Sam frequently visits his GP, but finds it difficult to discuss all his needs in a brief consultation. If Sam can't get hold of his GP in a crisis, he calls for an ambulance. Each time, Sam spends time in A&E, and is often transferred to a ward as well. He sees lots of different healthcare professionals and has to explain his conditions repeatedly. Frustrating. And Sam often has to wait to be assessed by social services before he can go home. The result? A lot of unnecessary time in hospital. And when he gets home, a lack of coordination between his GP and social care often means he doesn't get the support he needs. Eventually, after several hospital visits in just 6 months, it's decided to admit Sam to a care home. But what if Sam's health and social care services were more joined up? Let's imagine one of Sam's carers is given overall responsibility for coordinating his care. For example, Kathy, a district nurse. Kathy meets with Sam, his GP, and his social worker. Sam explains that he wants to manage his conditions at home, and together they design a care plan which they can all access online anytime. Sam now gets more visits from Kathy at home, which helps him manage his emphysema and diabetes. On the occasions when he does have a crisis, Sam calls Kathy rather than an ambulance, so goes to hospital less frequently. And even when he is admitted, he's discharged after a quick review of his care plan rather than having to be reassessed. In this scenario, Sam's health and social care is funded from a joint budget, so the team can make smart decisions about how it's spent and call on the help of other social services. For example, as his condition deteriorates, the team decide to fit a seat in Sam's shower, provide him with an oxygen cylinder to ease his breathing, as well as a medication dispenser with a voice prompt to remind him to take his pills. Kathy talks to Sam about his loneliness, and he agrees to weekly trips to the shops with a volunteer from a local befriending charity. So now, Sam doesn't have to be admitted to a care home, instead getting the help he needs in his home. He feels happier, is healthier, and better use has been made of resources within the system. Let's recap on what transformed Sam's care. Put simply, local leaders in the NHS, social services and the voluntary sector created a shared vision of what good integrated care looked like, centred around the needs of people like Sam and their carers. They pooled resources across health and social care, built multi-professional teams and created systems to allow Sam's information to be easily shared. Sound idealistic? Well, this is actually already happening in a few places. Now it's time to make sure it happens everywhere. Let's reimagine how we provide care. Get inspired at kingsfund.org.uk/joinedupcare.
Okay, so I think that quite sort of neatly, if you like, encapsulates why it is we want to try and integrate care services better. And I think when you look at something like that, actually, you realise that quite a lot of these bits and pieces are already happening for us. And that's, I think, a function of being perhaps relatively rural, but also the fact that we've traditionally had very good working relationships. But there are also elements there that are clearly not right. So there are still issues about the way we share information, for example, about that whole process of making sure that the plan is easily visible for all the people who have a role to play, and knowing how to access some of the other support services around volunteering, around befriending. So I think that there are lots of good things happening, but also there are lots of opportunities for us. And much of what is in that little video clip is really referenced in the 2020 vision. Is that something that you're familiar with? 2020 vision. It's a government policy statement about reshaping care for older people, particularly, but also about integrating health and social care. And it talks in terms of the three priority areas: quality of care, health of the population, and sustainable use of resources, about things like looking after somebody with multiple problems, making sure it's patient-centred or person-centred, making sure it's safe, that it's integrated in some sort of a way, but also that it deals with health inequalities, thinks about prevention, and uses that whole range of resources in a more efficient and productive way. So there are no great surprises in there for us, which is kind of reassuring, I guess. And obviously, in Annandale and Eskdale over the last couple of years, really, we've been doing bits and pieces of work around thinking about how the integration might work for us. We've had workshops, we've had seminars and so on. And I think really what has emerged, if you like, is a number of ideas around, for example, the importance of community, how you actually use the community in a more effective way to understand what is needed, and actually understand what assets are available there to actually support the processes of change. Clearly the centrality of team working is critical. If we don't actually have effective teams working together, then it's very difficult to coordinate and integrate care. But also we've seen the importance of sharing information and the need to look at alternatives, and obviously we've done various bits of work, for example, looking at alternatives to admissions to hospital, particularly in Annandale. But perhaps most importantly of all, we recognise the value of this different sort of approach, this enabling individuals to take more responsibility for their own care. And that's a very challenging thing to do, because culturally it's not necessarily what the service has done up until then. And a lot of that really has come from some of the stuff we've done through Putting You First. Putting You First is again a government programme supported by something called the Change Fund, which was a 3-year funding stream which is about to come to an end in March. And again, it was very much about this idea of reshaping care for older people, and the opportunity to do that in an innovative way. And we've had various projects running in Annandale and Eskdale around engaging with the community, around this idea of alternatives to admission to hospital, but also stuff around anticipatory care planning, so planning for when something might go wrong, if you like, so that the individual knows what will happen, the family knows what will happen, the carers know what will happen if somebody becomes unwell or falls, or and that's about making sure that the care is most appropriate and avoiding unnecessary admissions to hospital. But also what we recognised was that in fact if you actually go and ask people what's important to them, what matters to them, and very often it's not very much about their health specifically, but about their ability to get out, to socialise, to go to the shops, to go and meet their friends, to go to the hairdresser. And so actually the opportunity to support them in that way, relatively low level support, actually is tremendously beneficial from their mental health, and ultimately also from their physical health, if it means they get out doing a bit of exercise. And also been engaged in some telehealth projects using technology in a different way. But I think probably the most important thing for me is a recognition that it's not one of these things that is going to sort all of our problems. Actually, there is no silver bullet. It's about the patchwork quilt that ultimately provides the blanket of cover of care, if you like. So why are we doing all of this? Well, obviously there's a real recognition now that people are living longer, and they're living longer with multiple medical problems. And this is just a piece of work that was done by Bruce Guthrie from Dundee University. And really what it tells us is that if we look at, as people get older along the bottom, that the proportion, the percentage of them who have multiple medical problems increases. So at the age of about 65, at least half of the population will have 2 or more medical problems. When you get to 75, it's 3 or more. And so that's a significant burden, if you like, of disease within the older population, which is increasing all the time. And not only does it create this burden of disease, but it creates a burden of treatment for the individual. And they have to remember that they've got medication to take for 3 or 4 different conditions. They might have clinics to go to, they might have appointments to keep it with the doctor, they've got the nurse calling, they've got the occupational therapist coming to fit a bath rail or whatever. So managing all of that for an individual becomes quite challenging, and things are forgotten, or they don't take the medication because they don't understand why they've got to take it. So there's a whole pattern of evolving multimorbidity, which is a key challenge for us. I think one of the other challenges beyond that morbidity and changing demographic is that we are also a bit of a sort of victim of our own success. The health service has been very good at doing things to people for 40 years, really, or more. And people have come to expect us being there to solve all of their problems. And we know that's not a sustainable model. The service cannot possibly cope with managing all of the medical problems, managing all the social problems for the individual. The individual now has to start to take some more responsibility for managing it themselves, and indeed the wider family group has to understand that those demands and expectations are not sustainable. And we all know about the financial problems that we all face, both in health service and in social services. And that's quite challenging, because obviously government doesn't stop setting us targets about what we're supposed to do, how quickly we're supposed to see people, how comprehensive their package of care is supposed to be. And so there are real tensions in not giving us the money, but also still telling us that we've got to do all of these things. We need to find ways of being quite creative. And underpinning all of that is this idea of culture, this idea that not only do we have communities which are expecting and demanding things of us, but we have a service which is culturally used to working in that way. And actually it's not in our nature to say, well, actually you're going to have to do this. We feel much more comfortable by saying, well, that's okay, don't worry, we'll look after it. And that whole professional approach is something that's really quite different. For the individual, just to reinforce this idea of encouraging people to take more responsibility. This says, so if I need to stop smoking and lose weight, what are you going to do about it? It's not an unusual situation. You know, won't you give me pills so I, you know, can look like Bridget Bardot, doctor? Of course, that's not going to work. What is it that motivates people to actually go and change the way they live their lives? This one says, what fits your busy schedule better? Exercising 1 hour a day or being dead 24 hours a day? You know, it's very difficult to understand what motivates people to exercise or to lose weight or to stop smoking. But we need to start thinking about how we change that motivation. So we've got some opportunities now looking forwards to grow some of the things that we've done with the Putting You First project. We recognise that real value of engaging in a much more meaningful way with communities and actually allowing us therefore to develop some sort of plan to think about the way we use the locality in a much more flexible way. But also traditionally in Annandale itself, we've been quite good at capturing resource, and by that I mean when there are programs or projects out there that might have some money associated with them, that we need to go and grab it and take that opportunity. So we need always, I think, to be aware that there'll be new bits of resource coming down the line. So, for example, supporting health and social care integration, there will be a national integration fund, which will be the sort of replacement, if you like, for the Reshaping Care for Older People change fund, Putting You First money, if you like. We need to think about how we use technology, but we also need to recognise that this is not something that's going to suddenly revolutionise or change significantly. Hi.
Sorry.
No, you're all right. Come. So it will be a growing process. It's going to evolve, and we just have to start from where we are, really. But what we do recognise is that we can't do it on our own. We have to do this together. This is who had start right shoes on when they were growing up. I thought this kind of neatly encapsulated the fact that, you know, we've got to do this hand in hand. We can't run off and do it on our own as a health service or as a local authority. And so if we do it together, we'll be able to walk happily ever after. As I said, this is Jimmy Marshall, the one with a nice hat. So how do we do some of that? Well, of course we need to have some sort of plan. We need to have a plan about what we need to do, and that requires us to understand what we mean by the needs of the locality. We need to understand the assets that we already have, and we need to go through that engagement process and plan action and evaluate and try and engender this idea of local ownership. And you'll see there's a recurring theme here. It's got to be local. For so long now, the health service has dictated how things should be. The management structures, if you like, are very directing from the top. And actually this is a real opportunity for us, I think, to grow something in a very different way that actually is much more responsive to the needs of individuals, to the needs of the locality. So as part of all of that sort of planning process, as I said earlier, we've had a number of sessions of workshops, and about 18 months ago we had one in Annan where Jeff Ace and Gavin Stevenson, Chief Executives of Health Service and Council, came along to give us some contribution. And they were very encouraging and said, you know, go on, get on with it, you know, it's in your hands. But remember that you need to think about where are you taking it? What's your objective here? What's your destination? You imagine you're on a bus journey, on the integration bus. Where's the bus going? What is it you want to? Where do you want to get to? Right. And so a few of us across Dumfries and Galloway were tasked with going away and thinking about that. What was it we actually wanted out of this? And so we've done a bit of work around this idea of transforming community services through that different engagement process, but particularly about encouraging this idea of individuals getting out there, living life to the full. And it's supposed to be sort of encapsulated in this vision. Now, our vision statements are a bit motherhood and apple pie sometimes, I think. But actually, I think in a form of words, this sort of captures the ambition, if you like, for Dumfries and Galloway about the responsibility to make our community a better place to live safely in a healthy way, about this idea of promoting independence and choice, but also that responsibility around using the resource that we have available responsibly. So that's what we came up with. And really the idea of that is that it needs to inspire people, it needs to then act as a foundation for further growth, for development of a different sort of organisation. But it's also about transformational change and about engaging with people in a different sort of way, as I said, particularly at a local level. Perhaps not all that surprisingly, the government would love to still tell us what we should be doing, and as a consequence they have come up with outcomes that they would expect to be delivered through this process of integrating health and social care. And I guess it's a bit of a relief that there are not any major surprises in there, and there are themes here that I've already sort of alluded to, really, about improving individuals' health. But actually it's about them being able to do some of that for themselves, about the opportunity to live independently or as close to home as possible. But also about the quality of services, about it being a positive experience, and also obviously the stuff about resources, about the idea that we need to continuously improve what we do and keeping people safe from harm. I think one of the most challenging ones for us, though, is this idea of reducing health inequalities. Over the last 20 years of health service reform, most of which has been geared towards trying to resolve health inequalities, all of which have failed miserably. Indeed, I think it's fair to say that probably if you go and look at the statistics now, health inequalities are even wider now than they were 20 years ago. So we need to think a little bit about how we engage it, again, at a community level, to address some of those challenging areas of health inequalities. And we don't live in an area of grinding deprivation like they do in parts of Glasgow, or even parts of Edinburgh. But we know that there are parts of our communities that are significantly more socially deprived, and those are the ones that we know benefit most from interventions, if you get the intervention right. So just in terms of where we're at, and this is a slightly horrible slide, but it's about really the timeline. So we're about here now, this is November, and basically all of these are legislation changes. So this is all stuff that has happened in Scottish Parliament to actually set the ball rolling around health and social care integration. And basically what we're aiming for in April 2015 is we need to have a plan in place, we need to have some arrangements in the locality which are essentially going to enter a shadow period between April 2015 and April 2016. So we need to have a sort of management structure in place by then. And we need to, I think, have scoped out a fairly robust plan, although that, by its very nature, would need to be an evolving piece of work, because it's not long until April to get planning sorted. But we've started some of that already. We need to submit, therefore, the integration scheme, I think, by the end of December, which allows us then to do that shadowing from April. And that's something that will be done by the joined corporate body, which is Health Board and local authority. As I said, Dumfries and Galloway have gone to this idea of a corporate body, which is a sort of separate organisation rather than one of the organisations taking the lead in all of this. They've agreed to set up a separate organisation, which will be the Health and Social Care Integration Programme Board. We've talked a little bit about the outcomes. We've agreed that the locality approach is the way forward, and now we're starting this process of planning within the locality around those outcomes. So if you look at those outcomes, you can identify within those themes some things that you might want to do, which will actually help you to deliver some of those outcomes, and that's kind of where we're at. And then planning for shadow arrangements. Type out. These slides evolve as every time I do this, and that was done in a bit of a rush. This is a horrible picture, but actually it's really just there to show some of the steps that have already been or are already being planned. It's called a fish diagram, because it kind of looks like fish bones, I guess. And in progress to achieving some of this, there are a number of themes around leadership, around setting up some sort of locality management, around engaging with staff and service providers, but then also engaging with community, and then this whole idea of culture change. How do you change the culture within the community, and indeed change the culture within the services? How do staff really start to understand what some of this is all about? And this is what some of these sessions are all about, really, about engaging with people in a different way, and helping them to understand that things have to be a little bit different. So, and all of these blobs are just things that we need to think about, we need to do over the course of that change process. So, I think I've probably said enough, really. Yep, definitely said enough. I'm very happy to take any comments or questions. That's been a bit of a rush through, if you like. It may not all be entirely clear, and that's partly because it's not all entirely clear, but if you've got questions, I can certainly make up an answer if I don't actually know it. Thoughts full of horror, completely gobsmacked.
Some other people on the corporate body.
Yes, and it's made up of sort of senior executives between health and council, Alistair. So,
I think we know who they are.
well, Julie White is the manager responsible for health and social care integration. So she is the executive director for that corporate body, and then below that there's representation from both council and health board, and I don't know exactly who's sits on that, but there are some non-executive directors and some elected members, so non-executive directors of the health board, elected members of the council, along with some of the other executives. So there'll be people from finance, people from human resources.
And the idea is that they're going to be Annandale and Eskdale.
So the corporate body is the thing that sort of sits regionally for Dumfries and Galloway, and really they have a governance role. In other words, they have a responsibility to make sure that the plans are in place, and there are monitoring processes that ensure that things are being delivered in the way that they should be. They're responsible for keeping an eye on the money and that sort of thing. Within each locality there will be a locality management group, board, whatever. I don't know that we've actually formalised a name for it yet, to be honest. And that is sort of in shadow existence right now. And again, so there's there aren't elected members involved in that process yet, although that may yet happen. But it is, so I participate, Jimmy Marshall from Social Services participate, Jamie Ferguson, who's nominally the locality manager for the Annandale and Eskdale local committee. Obviously John and a range of other individuals from across sectors, Alistair, are sort of meeting somewhat intermittently, but that's a function of this sort of being added on to everybody's day job a bit, actually. And one of the things that we recognise is if within the locality we're going to get our act together, then actually we do need a bit of capacity to manage all of that and organise all of that. And again, there is a plan to appoint a locality manager, and John in his role as locality coordinator at the moment, which is particularly from health. We're hoping might be persuaded to stay on for a bit longer to sort of facilitate some of that. He doesn't know that yet. And we need clerical support. Just organising stuff like this takes time. Yeah.
Neil,